Hi, I'm Narthana Kambalapalli.
Hello, my name is Anna Delot.
Hi, my name is Erica Am.
And I'm Preksha Jirajani.
Judges, will you now introduce yourself with your name, academic degree, and current position?
Brian Sick. I'm a physician here at the University of Minnesota. I'm the Associate Vice President for Academic Health Sciences.
Good afternoon. My name is Chris Myers-Janda, and I'm a Vice President for Premier. Academically, I have a Master's in Healthcare Administration and an undergrad in Physiology.
Hi everyone, my name is Carolina La Rosa Mateo. I have a Master's in Public Health, and I'm currently the Director of Operations at a nonprofit called ASER.
Good afternoon. I'm Eric Maurer, the Innovation and Strategy Officer at Kook. And academically, I hold a Master's in Healthcare Administration as well as a Master's in Health Informatics, and my Bachelor's is in Psychology. Thanks for focusing on Kook.
Good afternoon. My name is Sophia Ali. I am a physician. I am the Medical Director at Southside Community Health Services, and I also have an MPH.
And my name is Paul Goering. I'm a psychiatrist and post-career advisor in strategy and innovation.
Thank you. Let us know when you're ready and we'll start the timer.
So, good afternoon. We are going to present our implementation and incorporation of the shared visit model within CUHCC. This is our table of contents, but before we get into too much detail, Narthana will talk more about the root cause analysis.
So our root cause analysis focused on three major points. We have reimbursement and billing, the patients, and the program structure itself. All three of these factors contributed to the ineffective implementation of the shared visit model at CUHCC, and therefore our solutions are going to address the uncoordinated care currently present at CUHCC, and also work to address the cost, time, and the disease states along with a functioning coordinated team. Next, we'll move on to Anna for the patient criteria.
So after conducting research on the patient population within the Phillips community, we created inclusion criteria as a way to determine what patients should be included in this model. So the criteria include first being already an established patient at CUHCC, being within the age ranges of 25 to 64, which we defined as the adult population, having insurance coverage of some sort, and lastly, being diagnosed with one or more of the following disease states, and those include hypertension, hyperlipidemia, diabetes, or asthma. And as you can see, patient A is the ideal candidate for our model. They came into the clinic, they're 62 years old, and they are here for diabetes management. And in considering these inclusion criteria, our goals for the patient are to help minimize symptoms, improve quality of life, prevent any unnecessary hospitalizations, and also encourage the patients to really have a say in their care. Next, Erica will discuss our pre-visit planning process.
So how do we admit our patients? So first we're going to have them check in, and they're going to fill out 3 forms. Our first form is going to be the personal questionnaire, and the purpose of this form is to really conduce this inclusive environment and help the patient feel empowered. And we're doing this by addressing language, culture, ethnicity, race. And secondly, we have the health literacy assessment by the AHRQ. This is going to gauge how well they can process and comprehend health-related information, and this is going to be relayed to the team so they can apply it. And lastly, we have the pre-assessment form. The patient is just going to report any changes to their health, their lifestyle, caretaker. And we also want to create a free space for patients to put their personal goals, because we just want to get to know them better as a person. And so next we have interprofessional team criteria by Preksha.
So meet the team. First, we have our internal medicine and primary care physician. They will be the primary contact for the patient throughout their medical journey, regardless of their disease state. Second, we have the nurse practitioner. They will also help the physician in helping the providing care to the patient. And also they will bring a diverse set of skills that will help diversify the treatment that we can provide to the patient. Third, we have the social worker who will be there to aid in patient-physician interactions and also empower the patient to ask any questions or comments or concerns that they might have regarding their treatment. And finally, we will have the pharmacist who will aid in treatment plans for the patient, including any medication changes that they might have, and also educate the patient in their prescriptions and therapy plans during and after the appointment. We also want to mention that all of these core members will also have the opportunity to go through additional training on mental health and wellness. We will also have a need-based position that can be filled by a variety of specialties based on their disease states and what the team considers the patient might need help with. And this is to reduce cost for the visit to the patient and also increase the collaborative efforts of the providers themselves. This also reduces the time it takes for the patient to make separate appointments and really works on centralizing care for them so that they don't have to manage different systems and different healthcare appointments. Moving on, Anna will talk about patient visit and orientation.
Yes, so prior to a patient's first visit within the model, they are required to attend a patient orientation. And we did this for a few reasons. I will note it's also, there's a virtual option and an in-person option. But our primary reason, and I'm going to give you an example, is that patient A came into the clinic for diabetes management. And they were concerned that they were sicker than they actually were due to the fact that there were so many providers having a say in their treatment plan. So really, this gives the opportunity to explain the opportunities and the benefits associated with our model. It also introduces the care team to the patient prior to the first visit. And lastly, it really demonstrates and helps the patient really understand how they can optimize their care by being a patient in this model. So next, we will talk about the technology gap with Erica.
So as Anna just mentioned here, we have two options for orientation. We have the virtual option and the in-person option. But we also want to address that within the in-person option, we're going to divide it into two subcategories. So we have a computer option, and we also have a binder option for those who are not as fluent in technology. And we think this is very important because orientation contains a lot of information, and we need to organize that information. So we're going to give tools for the patient to navigate through the binder as it can be bulky. And this is going to be given to them, maintained with them throughout the visit, and also taken with them at home so they can refer back to it. And next, I'm going to be moving on to the overall model structure by Praksha.
So we've heard about the pre-visit and pre-intake where the patient gets to put in their information from previous visits and for them to address any changes that they have gone through previously before entering the shared visit model. Then we move on to pre-rounding and preliminary assessment. This is where the team meets with the patient and also has time to come together as a team to come up with a treatment plan for the patient. And then we move on to discussions with the patient. This is where the team will discuss the treatment plans that they've come up with as a collaborative effort. And this is also a space where the patient can raise any concerns that they might have about their treatment plan or about the overall visit. And finally, the next steps will involve a post-survey and follow-up appointments that can be made for their next visit. Anna will now take over dedicated spaces.
Yes, so a unique aspect of our model is that we have created a shared discussion space between the providers and the patients. So this is an opportunity for the patients to bring in any family, friends, or people that are pertinent to their care. And beyond that, we have delegated the task of discussing the new treatment plan for the patient to the primary care physician and the social worker. And that's to ensure that the environment is comforting and casual, and also is conducive to the patient and their needs. And it also gives the opportunity for the patient to voice their concerns and also just have a say in their care. So next we will discuss the timing of visits with Narthana.
All right, so our visit is divided into 3 levels of complexity. So how this is determined is going to be based on the pre-assessment form that the patient fills out prior to the visit. The care team themselves is going to determine where this patient is going to fall within the criteria that are listed above. It's important to note that the timing of one visit is independent of the next visit. And for example, with patient A, we saw that they were coming in for a diabetes management concern. And so depending on what their pre-assessment form lays out, what it says, the care team will determine where the patient will fall. Next, we're going to talk about the weekly team schedule with pressure.
So the weekly team schedule here is to address that the care team themselves will be on a rotating basis. This will allow for us to not have long and unusual hours and not overwork the providers, but also allow increased accessibility for patients who have different busy schedules themselves. And the overall goal here is to, again, not overwork the providers and the team members, but also increase the amount of patients we see on using this model. Next, we will talk about billing based off of our complexities with Nirthana.
All right, so we wanted to move from a more traditional fee-for-service based model to a more value-based care model. This was to ensure that we provided a collaborative environment for our care team and also made sure that the patient was at the center of our care and making sure that they were getting a cost-effective but quality care. Under this model, since our focused patient population is covered by insurance and CUHCC is a federally qualified health system, we thought that the use of CPT codes would be good for tracking health utilization of the program itself and also determine the cost of the program to the health system. Next, we move on to post-visit plans with Erica.
Yeah, so what happens after the appointment? We're going to ask the patient to fill out a post-visit survey. This is just to gauge their satisfaction with their care and also enable them to switch providers as needed. We also have social work who's going to help ease the transition from the clinic to outside. And with patient accessibility, I just wanted to reiterate the patient portal through the binder or through the online MyChart. Both are accommodating to virtual learners and also those who are not familiar with technology. And we're also going to be addressing that language barrier by adding in the binder option with the proposed language that the patient would prefer. And next, I want to move on to community engagement. So obviously, it's very important to engage the community in this model as they are a very important aspect. And how are we going to integrate the community? Well, one way to do that is to provide a list of resources for patients. An example of this is through CUHCC's list of resources for them to refer to if they need continued care. Additionally, if there are other organizations that may be of benefit, partnering with nonprofit organizations is a very viable option as well. And the way we're going to implement all of these is to involve the board of directors to finally implement all of this into reality. And next, I have Program Success Management by Anna and Narthana.
So in order to measure the impact of our model, we decided to use 5 different parameters. So the first was patient follow-up. Are they continuing to use our model, and are they satisfied? Our second one was survey analysis. So from the post-visit survey, we're going to utilize that data directly from the community and the patients to implement, whether it be the workflow or general specifics within the model, to really make sure we're accommodating the patients in the community in the best way we can.
Something else we'd like to measure is the emergency department readmission rates. One of our goals of treatment was to prevent unnecessary hospitalizations, and we feel by determining the readmission rates, we can see if that goal is being met or not. Next, we also want to look at CPT code tracking. I did mention earlier in the billing that this would be a good way to determine the utilization of the program itself. And then lastly, we want to look at the timing of the visits. So are we seeing patients move from higher levels of complexity to lower levels of complexity that are involved within our program?
So based on what you all heard today on our model, what are we aiming to achieve? We are aiming to improve the overall population health and then improve our patient experiences in the healthcare system. We also want to make sure that we incorporate team well-being, because we do understand that providers have different schedules and other aspects of their life that they want to get to, so we want to address those. And finally, we want to increase the efficiency of the healthcare that we provide and also reduce the cost for the healthcare that is provided to these patients, and keep the patients in mind and at the center of all the models that we propose. Thank you for joining our presentation. What questions do you have? These are